Hi, everybody. Let's get started. I know there are still some people trickling in, but we want to try to keep this on time as much as possible. So it's great to see so many of you here today, and hello to everyone who's also tuning in via Facebook Live. So welcome to the Division of Health Policy and Management here at the University of Minnesota School of Public Health, where our mission is advancing health and healthcare for all through evidence and education. So I'm Ezra Gulberstein. I know some of you. I'm part of the faculty here in the Division of Health Policy and Management. Our event today is co-sponsored with the Minnesota Council of Health Plans, and Julia Dreyer from the Council is going to introduce our very special guests.
Great, thanks Ezra. Again, I'm Julia Dreyer. I'm with the Council of Health Plans. We are super excited to be co-sponsoring this event today. And we are also very excited to introduce today's guest speaker, Margot Sanger-Katz. I'm sure many of you are familiar with her work with the writing for the Upshot, the New York Times site about politics, economics, and everyday life. And before joining the New York Times, Ms. Sanger-Katz was a reporter at the National Journal and the Concord Monitor and an editor at Legal Affairs in the Yale Alumni Magazine. And also joining us today to help lead our conversation is Gary Eichten. Mr. Eichten is an NPR news editor at large and a retired program host. Mr. Eichten held several positions during his 40-plus-year career at Minnesota Public Radio, including news director, special events producer, and station manager. He served as an anchor for Minnesota Public Radio's live special events news coverage and anchored all of the major news programs on Minnesota Public Radio, including Midday, which he hosted for more than 20 years.
So our format for today is that Gary Eichten and Margot Sanger-Katz will kick off the discussion for about 45 minutes. After that, we're going to be taking questions from the audience. Because we are such a big crowd in a pretty big room, the way that we're going to do that is that if you have a question for Gary Eichten and Margot Sanger-Katz, please write it down on the note cards that hopefully you were given. And in about 30 minutes from now, someone will be coming down to collect the note cards, and we will then deliver them up to the stage for Gary to ask them to Margot Sanger-Katz. So everyone will be able to hear. With that, please join us in welcoming Gary Eichten and Margot Sanger-Katz.
All right. Thank you very much. Margot, welcome to the U of M.
Thanks for having me.
By the way, Minnesota Public Radio is recording our conversation today, so we all may end up on the radio sometime soon. Don't swear or anything today, you know. I'm going to be mixing in those questions a little later, but I'd like to start, if I may, with a few easy ones for you, Margot. You know, just kind of general yes and no type things. How about this one? Are most people satisfied with the quality of their health care and their health care coverage? Just an easy one, huh?
No, so I know the answer to this question because we just did a poll.
And the answer is
yes. The answer, a little bit surprisingly to me, is yes.
So despite all the hand-wringing over healthcare policy, actually most people are happy with what they have.
I think that people are not extremely happy with what they have, but they are happy enough with what they have. And I think that is a real challenge for policymakers, both people who defend the status quo and people who want to make changes, that there's lots of things, little nagging, annoying, terrible things about the healthcare system that people would like fixed. And so they're not very happy with just the status quo, but they are happy enough with the status quo that they are aware that they could lose things if changes don't work well.
Affordable Health Care Act, the ACA. Another easy one for Margot. Did the ACA solve most of the major healthcare problems facing Americans? Did it solve some of the healthcare problems facing Americans, or did it solve almost none?
So I'm going to choose B. So the Affordable Care Act, I think that there is really good evidence that the Affordable Care Act helped with certain things. It reduced the number of Americans with no insurance pretty substantially. In the neighborhood of 20 million people now have insurance that wouldn't have had it in the past or wouldn't have had it in the absence of the Affordable Care Act. So that is a big achievement. I think it increased the sort of generosity and robustness of insurance coverage. So it used to be that you could buy insurance and then you'd find out later that there were just huge holes or caps or limits. So the Affordable Care Act said, you know, okay, like you're going to sell insurance, it needs to have some minimum standards. And so I think that has provided people with access to care and financial protection that wasn't available before. There is some evidence, I would say it's like more marginal evidence, that the Affordable Care Act has led to some public health improvements, certain populations getting care that they wouldn't have gotten before that seems to be making them healthier. That evidence is like not as robust as maybe I would like it to be, but it makes sense because, you know, 20 million is a lot of people, but it's not that many people relative to the whole population. So you want to find differences in these disease states. It's sort of hard to collect that data. And then there is some pretty good evidence that the Medicaid expansion part of the Affordable Care Act has had like good financial effects for low income people. It's provided them with additional financial stability. So not just the ability to access healthcare, but less debt, less bills, fewer bills in collection, and sort of that is not a healthcare aspect, but I think it is a reflection of the fact that giving people insurance, that's a financial product too.
Now, we used to hear about a lot of people going bankrupt because of medical costs, medical bills. Is that still the case, or has that problem been ameliorated?
So we don't have good evidence about the answer to that question. That research actually is sort of a contested area of research. So the numbers that are most often cited about the frequency of bankruptcy related to medical bills come from research on people who had already declared bankruptcy. So that research Elizabeth Warren was involved in, along with a couple of other researchers who study bankruptcy and studied healthcare. And so they like basically took this sample of people who were in bankruptcy and they asked them, you know, like, what were the problems with your finances? And they found that a lot of them said that they'd had a medical bill or that they had income losses because they were sick. And so they took that and kind of extrapolated out and said, okay, there are so many medical bankruptcies, and that what they found is that the majority of bankruptcies included one or both of these aspects. But health economists who study bankruptcy say that's actually like not a very good way of measuring how often people's medical bills lead them into bankruptcy, because it may not be the thing that caused the bankruptcy, basically. You know, maybe you have a medical bill and it would have just been there anyway and you would have continued to not be bankrupt. I happen to think that bankruptcy is a little bit of like a weird and specific thing to focus on. It's, you know, the bankruptcy system is a form of insurance. It's largely accessible to people who actually have enough money to pay to go to court and declare bankruptcy. And there are lots of other ways that the costs of healthcare affect people's financial security. But anyway, to get to your question, we don't have good time series data on this. There's one update of that survey that has happened since the Affordable Care Act was passed, but not terribly far into its life. It's not super recent. And that study found basically no effect using that same methodology of asking people who had declared bankruptcy. But there are also other changes in this period. You know, the bankruptcy law itself changed. Again, not to change the subject, but I just wouldn't focus so much on bankruptcy. I think there are other measures of the financial aspects of care that may be more revealing.
Is there one more easy one? And then we'll get to more difficult problems.
Yeah, is it possible to turn up the microphone?
That's what I'm trying to do right now.
Okay.
One more easy one while we're getting that taken care of.
Thanks for asking for that.
Is there an easy way to explain why it is that the United States is one of the only, if not the only, developed country in the world that has so much trouble providing everybody with health care coverage at a reasonable cost?
I don't know if that's easy. I think it's some combination of just historical choices that we made, that some of which may have been kind of arbitrary and could have gone a different way. And I think it reflects our political culture here to some degree. But I think, you know, you often hear from advocates for major health reform, you know, folks who want a universal healthcare system of some sort in the United States, that, you know, if you look at every other developed country, they cover everyone, they pay much less than us.
Right.
If we could just have a system like that, we could get the outcomes that they have. And I think that factual statement is totally true. You know, like the United States, we cover fewer people and we pay more for healthcare, and we have declining life expectancy and all kinds of other worrisome health outcomes that suggest that we're paying all this money and we're not really getting what we ought to relative to other countries. But I also think that because we are in this place now and these other countries made those decisions a long time ago, it is not so easy to just flip a switch, change our policy, make our policy more like those other countries, and then make all of the other things about our system more like those other systems. We sort of, in some ways, are going to have a uniquely American transition if we make a change, because we're starting from a different place than those places started from when they changed their systems.
Lots of coverage, primarily because of all the political debates on what the Democrats have been talking about in terms of ways we could possibly change our healthcare system. Focused primarily on Medicare for all versus, you know, the ACA plus a public option and stuff. And then that's gotten a lot of coverage. We can talk some more about that as we go along. But I'm curious, what are Republicans these days talking about in terms of healthcare reform?
So I think in terms of the kind of healthcare reform that has to do with changing the nature of people's health insurance coverage, so things in the category of, you know, what Democrats are talking about in the presidential race, or even repealing and replacing the Affordable Care Act, which was a Republican cause for, you know, almost the last decade, they are not saying very much at all. We don't really hear Republicans coming forward in this time with a plan to try to reform the health insurance system anymore. I think, you know, they tried in 2017 and were unsuccessful, and it was very politically damaging to them to not be successful and to put forward this policy that turned out to be very unpopular with the public. But I do think that we see Republicans in Congress and also the Trump administration doing a lot of things in health policy that are kind of not as closely related to health insurance, but that are sort of ancillary and that are kind of interesting. So just last week, the Trump administration finalized a policy that would require insurers and hospitals to publish all of their negotiated prices. So this is like not what is your copayment, but like the hospital and the insurance company, you know, duked it out and decided that when you go in for your doctor's visit, the insurance company, your insurance is going to pay this hospital, you know, $100. That data is now public. That's like a brand new policy. It's kind of unprecedented actually in this country. It's going to be really interesting to see what happens from that. There's also a whole bunch of policies that are more bipartisan than just Republican, but that are coming in part due to the leadership of Lamar Alexander, who's the Republican chairman of the Senate Health Committee, to try to lower healthcare costs and try to get some like weird incentives and inefficiencies out of the system. And that package includes an effort to eliminate surprise medical billing. So that's when you go to the hospital and the hospital is covered by your insurance, and then you like, surprise, get treated by a doctor who doesn't take your insurance, who sends you a big bill. They want to try to fix that problem. And there's a bunch of other sort of wonkier but very interesting stuff in that same bill that Lamar Alexander is proposing. So I think what we see is Democrats are really talking about how to change the coverage system, not entirely, but primarily that's where that discussion is. Republicans have retreated a little bit on that, but are still doing stuff to try to influence the way healthcare is delivered and try to squeeze some cost out of the system.
I was going to ask you about this change in policy the Trump administration has come up with, where insurers, hospitals, and so on have to publish their prices up front, more or less. What is the thinking on that, Margot? I suppose if I need an MRI, the idea would be that I would go, and you're giving that MRI at $100 cheaper than this guy, or that I'd go to see you. But what incentive would there be for me to do that? Wouldn't I simply go wherever my doctor told me to go?
So it's possible that you would just go wherever your doctor would tell you to go. There's pretty good research showing that probably is the most important consideration for you. If you have a high deductible health insurance plan and you're going to have to pay the whole cost of your MRI, you might care about that $100 if you knew about it, if you could look into it, if they were equally convenient. Oh, they told me to go down. Yeah, of course.
Is that better? Make any difference?
Sorry about the acoustics, guys. But the other theory is that making that information public is not so much supposed to have an effect on you, but it's supposed to have an effect on other people in the system, including maybe your employer who buys your health insurance. So they don't know. They're just, the insurance company says, like, insurance company A says, $10,000 a year for your insurance. Insurance company B says, like, $10,500 and they pick the $10,000 one. This will allow those buyers to look under the hood and really understand what the different insurance companies are paying. And maybe they will say, well, hey, like, your package looks okay, but it seems like you're really paying a whole lot to send people to this hospital. Can you go get a better deal with them? Or could we cut them out, or whatever? It would enable, the idea is that it will empower more actors in the system to try to negotiate harder. And I think there's also a view that it will sort of name and shame certain healthcare providers that are charging really outrageous prices. We see these stories in the paper about like the $1,000 Band-Aid in the emergency room. Maybe if that information is easily accessible by the public and by advocates and by other people, there will be some disincentive to have a negotiated price of $1,000 for the Band-Aid, because both the insurer and the hospital will be embarrassed by that. But one of the reasons I think this policy is so interesting is it actually turns out that there are quite a lot of health economists who think that it could backfire. They think that there is a chance that actually making all these prices public could tend to raise and not lower prices, which is fascinating and counterintuitive, but
What's the thinking?
So the thinking is, this is so crazy. The thinking is that in the 1990s in Denmark, there was a regulation of concrete manufacturers where they had to publish the prices that they were charging for concrete to contractors. And just bear with me. So I learned a lot about concrete. So it turns out that concrete, that's the stuff that goes in the truck where you feel the truck is mixing it and it can't drive that far or the concrete just hardens. So you have a relatively local market for concrete. There's maybe only, in any given market, maybe like 2 or 3 people selling concrete, because other people would have to drive too far with their concrete and it would just dry up along the way. And what happened is that once the prices were made public in Denmark in the 1990s for concrete, all of the concrete makers knew whether their competitors were giving certain customers special discounts. And they all stopped giving those special discounts because they wanted to keep their overall prices high. And they were able, over time, to basically raise their prices. And every time one would raise their prices, the others could see. And they're like, we could try to compete, but if we just raise our prices too, then we can all make more money. And so there's this idea that when you don't have a lot of competitors in a market and the prices are very public, that you can end up with this kind of tacit collusion where all of the parties stop giving discounts and start raising their prices in concert. And again, this is Danish cement. This is not the American healthcare system, but there are a lot of markets where there are just like 2 or 3 big hospitals. So there's not like unlimited different people competing for a business. There's just a couple. And so there's this concern that in those kinds of markets, that maybe making these prices public would allow the hospitals to just raise their prices together instead of try to negotiate for the lowest price.
Is there any consensus about the best way to actually hold down or even reduce healthcare costs?
I don't think there is great consensus about that. I think that there is consensus in the scholarship that compares the United States to other countries about what the biggest problem is here. So what it looks like is that the thing that makes the US the most different from the rest of the world is not that we use a lot more healthcare services than other countries, but it's that we just pay higher prices for everything. So if you compare the US to other OECD countries, other sort of peer countries, like we pay doctors higher prices, we pay hospitals higher prices, we pay higher prices to pharmaceutical companies and to medical device manufacturers. And so if we're using the same approximate number of medical services, but we're paying more for each one that we use, then that is what leads to our system being more costly. But when it comes to how to lower costs, I think there actually is not consensus. So there are some people who really think that what we have to do is do things that work on prices because that's where the extra money is. And then I think there is another group that thinks that what we have to do is figure out where people are using the healthcare system wastefully or in ways that harm instead of hurt them. That harm instead of help them. If we can sort of take out that care that's unnecessary or counterproductive or wasteful, then there could be money saved there too. And I think both are probably true. We could have the same amount of medical services as other countries and still have a lot of unnecessary care. It may be that those countries do too, and they just haven't been paying attention to it. But I think you see among people who are trying to lower healthcare costs to sort of interest in both types of cost containment.
Is there any consensus about what would happen if you actually did reduce prices? If you could, like prescription drug prices, if you went in and negotiated a real low, much lower prices, convinced the hospitals they couldn't charge what they were charging anymore, doctors couldn't charge anymore. Is there any consensus as to whether we could continue to have the quality and accessibility of healthcare that we currently have?
I don't think there's like a definite factual answer to that question. Like, I don't think that we entirely know. I think that it is important to realize that like every dollar that we're paying that we think is too much is someone's income. And so probably we're not going to be able to reduce the number of dollars that we're spending in the healthcare system without hurting someone. You may decide that, you know, a well-paid surgeon can afford to take a haircut so that more people can have health coverage. I think, you know, that's the ethical question that, you know, you have to decide about. But, you know, you can be sure that that person is going to feel worse off in that environment. Maybe that person is going to behave differently. Maybe on the margin, some smart person who might have gone on to be a surgeon will decide to go into some other higher paying profession instead. I don't know the answer to this question. I mean, we do know that in other countries, medical care is less expensive. People who work in the medical system make less money than they do in the United States, and the quality of care is pretty good. So maybe there's some ability to squeeze it out, but I think we shouldn't assume that it will be without costs and frictions if we do it, because it will require a lot of change and reorganization of how things work now, and there will be some disruptions associated with that. I think drugs are kind of a special case because basically the United States mostly finances pharmaceutical innovation for the whole rest of the world. So like our doctors here aren't providing care to patients in other countries, so we can sort of say, okay, we pay more, they pay less, how's it working out? But when it comes to drugs, we pay all this money you know, in really high drug prices, and then other countries get the same drugs for less. And we don't really know whether the pharmaceutical industry would still make as many drugs or the same kinds of drugs if they couldn't make as much money on new inventions in the United States as they do now. So it is theoretically possible that the whole world could suffer if we paid less for drugs, because people who are investing in drug research now might turn around and put their investments in some other higher yielding application. And so, you know, depending on what you think about pharmaceutical prices, you tend to come out differently. There are certainly, you know, if you talk to the industry, they say, like, if you take $1 out of our pocket, all the innovation will dry up and we'll have no new inventions. That seems probably wrong. And then I think there are people who say, no, 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 the rest of the world pays these lower prices. We should pay these lower prices too, and it will be without any cost to future inventions. And that seems wrong to me too. But I don't think we have a really fine-tuned model of like exactly how much you can push down the prices without having a big effect on the pipeline. We're probably going to find that out. I mean, both Democrats and Republicans seem really committed to pursuing policies right now that will lower the price for pharmaceuticals, and so we're going to see.
Now, in terms of healthcare costs, a couple of years ago, you wrote a very interesting article, I thought, asked the question, why should a 60-year-old man have to buy a plan that includes maternity benefits that he'll never use? Say nothing of 72-year-old men. I mean, the theory is, look, if you only had to pay for what you were likely to use, rather than a full list of all these other things, presumably it'd be a lot cheaper for that person. So why isn't that a U.S. healthcare policy?
So I think that narrow question, which came up a lot during the debate over repealing the Affordable Care Act, is actually a version of a question about why do we have insurance for healthcare instead of why don't we just pay for it directly. So if everyone just paid for the specific services that they used, you know, you paid cash every time you went to the doctor or the pharmacy counter or the hospital, for most people, like that would probably be cheaper than what it costs to buy health insurance, because most people don't get sick in any given year and need a lot of healthcare services. Or maybe if they get sick with something that doesn't require a lot of cost. You know, they have a generic antibiotic that they take for an infection or something like that. But there are some people who get really sick and incur really high healthcare costs, and it's not totally predictable who those people are going to be. Who is the person who's going to be diagnosed with cancer tomorrow? Who is the person who is going to have a child with a rare genetic disorder? Who is the person who's going to be hit by a car on their way home this afternoon and need, you know, major reconstruction? And so you know, the reason that we buy insurance is because we don't know what's going to happen to our health in the future. And so the goal of insurance is to try to spread the risk out over a lot of people. Most of them are going to be healthy. Some of them are going to be sick. And if you kind of average out the cost of caring for this large group of people, then maybe the cost of the insurance will be affordable for each of those individuals. And, you know, one of the things that the Affordable Care Act was really grappling with is, what is the stuff that we want to have in that package that everyone gets access to? Because if we go to a model where it's a la carte, where people are just paying for the stuff that they need, it's going to be really expensive for the people who get sick. And if we go to a system where absolutely everything is covered, then it's going to be really expensive for the healthy people. And so this is, I think, a constant tension in our health policy debate is, you know, how do you make insurance generous enough that it's meaningful, that people who get sick actually get the care they need and aren't financially ruined by it? But how do we keep insurance affordable enough that people who are healthy and who have constrained resources aren't spending, you know, huge chunks of their income on health insurance that they don't get a lot of day-to-day benefit out of? I think pregnancy is a really great example of this. Like, you know, it's not the same as getting hit by a bus. You know, a lot of pregnancies are planned, but a lot of pregnancies are not planned. Obviously, only women get pregnant. And so I think it comes to this question about, you know, are we going to spread the cost of this across everyone, even people who are never going to need this service? If we do that, it will be more affordable in general because, you know, pregnancy is something that happens to a relatively small percentage of people. If we put the burden of paying for pregnancy and childbirth just on the population of people who are most at risk of having that condition, then it's going to be really expensive for them, and maybe some of them are going to end up not getting the care that they need.
Mm-hmm. What about these short-term plans? They were meant, as I understand it, initially just to serve as a kind of bridge. You know, you lose your insurance, they buy the short-term plan, pretty stripped down, bare bones, but then you're going to move into a richer program. But now the thought is, well, why not just let people continue on in the short-term programs? If you had full disclosure for people, what would be wrong with that? If people knew in advance, I'm going to buy this policy, it's only going to cover 2-3 things and everything else I'm on my own, what would be, from a policy standpoint, what would be wrong with that?
I think, you know, this is a version of the same question, and I think that there is real disagreement about whether there's something wrong with that. We see the Trump administration has really loosened up rules to allow these kinds of plans. They cover fewer services. They deny coverage to people with pre-existing health conditions. They are not in keeping with what the Affordable Care Act wanted insurance to look like. But the perspective of the Trump administration is that there are a lot of people who can't afford insurance right now because Affordable Care Act compliant health insurance is really expensive. If you are relatively low income, middle income, you can get some financial assistance through subsidies, make it more affordable. But if you earn more than a certain threshold, you're on the hook for a health plan that can cost, you know, $10,000, $15,000 in some markets. And, you know, some people just don't have that money. And so the argument for these plans is, yes, they are not as good. They don't cover as many things. Not everyone can get them, but maybe something is better than nothing. And maybe we should let people make those choices for themselves. People who dislike this kind of insurance have basically 2 objections to them. One is just, you know, sort of a little bit of like a paternalistic concern, which is, it's really hard to shop for this stuff. People aren't experts. They're not reading the fine print, or they don't understand what the fine print is. It's very easy for someone to get into a situation where they buy something and it turns out not to be what they thought it was. And in fact, we're starting to see more and more stories like that. People who were sold a plan, an insurance broker told them that it covered everything and it has all of these holes, and then they got sick and they ended up, you know, with huge bills without the coverage they thought. The other concern is that obviously if you have one product, an Affordable Care Act insurance product that anyone can buy regardless of whether they've had health problems in the past and regardless of whether they anticipate needing lots of benefits in the future. And then on the side, you have the skimpier stuff that only really healthy, risk-tolerant people can buy, that you're going to end up with the healthy, risk-tolerant people in one market and the sicker people over here, and that's going to raise the cost of the comprehensive coverage, and that's going to make it even more unaffordable for people who are healthy.
Now, the Trump administration has joined that lawsuit, which in essence would invalidate the ACA altogether. What would happen in America if that actually comes to pass?
Whew.
Another easy question, a little softball.
Yeah, so this case is basically making the argument that the entire Affordable Care Act is unconstitutional and should be like sort of wiped off of the law books. And that is just such a huge change from the way things work now. So if a court did that, there's like the kind of famous popular stuff about the Affordable Care Act that would go away. So those subsidies that I mentioned that help people buy insurance, those would go away. The rules about what insurance has to cover and who can buy it, those would go away. The Medicaid expansion that's covering, millions of low-income people around the country would go away. But there's like lots of other stuff that would also go away. Like the Affordable Care Act really changed the way that Medicare pays for all different kinds of healthcare. And that is a currently operating program that lots of people are enrolled in. I don't even know what it means to pull it back. The Affordable Care Act established a process where generic-like versions of biologic drugs could be developed and approved by the FDA. Those drugs are on the market right now, and there are many of them in development in the pipeline. Suddenly those wouldn't have any kind of legal authority. There's like a million other weird examples like that. This was a very large law that touched a lot of parts of the healthcare system, and to kind of rip it away would be enormously wrenching and disruptive. That said, it did sound like the court that is considering this case, there's a 3-judge panel, and they asked questions of the parties in an oral argument, and people who were in that room said that they thought that at least 2 of those judges were extremely sympathetic to the argument that the Affordable Care Act should be invalidated for legal reasons, not necessarily for policy reasons. And so I may be writing a lot more stories in the future about what the consequences of that kind of decision will be.
Well, a couple of years ago, though, we were told that if the individual mandate were eliminated, this is the thing that where you were required to have health insurance, you had to pay a fine. But if that were eliminated, probably the whole program would fall apart. Well, it was invalidated and the whole program didn't fall apart. So how much good information are the policymakers actually working with? There's so many things that seem, well, on the one hand, on the other hand, we don't know, there are consequences, blah, blah, blah.
I mean, we do a lot of new things in this country that haven't been done before, that haven't been tested before. And so I think there's like interesting economic theory about it. The people who thought that the individual mandate was really important had evidence from other kind of similar examples that they were drawing upon, but they didn't really know. And I think this is a good example of like why it's important to have some humility about all of this and predicting what the outcomes of policy changes are going to be. We don't really know. There could be some surprises. There is an argument that I sort of like. I don't know if I believe it, but I think it's interesting about the individual mandate, which I call the "'tis better to have loved and lost than to have never loved at all," which is that it may be that if there had never been an individual mandate, it would have been a big old mess. But because we had an individual mandate and then we took it away, it was not so bad. I don't know.
Are people, you got the policymakers here. Is the general public getting, you're in the media, one of the nation's top reporters in this area, are people getting the information that they need, the average Joe and Jane, to understand all of this debate on healthcare policy and make choices that they're supposed to be making?
Oh, I really wish the answer to that question was yes, but I think the answer is almost definitely no. I just think, first of all, this stuff is really hard. It's really complicated. It's like almost intentionally complicated. I mean, our system is just really, really hard to navigate for normal people. And I also think people are really busy, and reading the news all the time is not always the biggest priority that they have. I sort of fantasize about a world in which everyone reads every article that I write, and then I see like public polling about awareness of various things, and I realize like no one has read anything. But I think that just like makes me in my darker moments a little bit despairing, but it also makes me feel like in more bright moments, like an enhanced sense of purpose, that there is a real need to educate people and explain things. People really care about this. It's important to them. It's important for their health and for their financial security. And so, we just like gotta keep trying.
How did you get involved in healthcare reporting as opposed to, I don't know, covering the crime beat?
So I've done some of that too. I was telling the story to some students at lunch, so sorry if I'm repeating it for any of you, but I came to healthcare reporting in a sort of roundabout way. I went to college and thought that I wanted to be a scientist. I thought I wanted to be a chemist, and I loved chemistry in high school, and I went to college and I took this like advanced chemistry class, and I loved the class, and then I had to work in a lab and actually like make chemicals. And it turned out that I was just terrible at it. I mean, just terrible. And I was trying really hard, but I don't know, just nothing, my experiments never worked. I could never make the chemical. And I was really frustrated by my badness at it too. So I thought maybe I could write about science instead of doing it, because I was still interested in the science part of it. So I thought I would be a healthcare reporter writing about like medical research and innovation. And then when I got I had a couple of jobs along the way, and then I finally got a job writing about healthcare at a paper called the Concord Monitor in New Hampshire, which was a relatively small paper. And, you know, covering healthcare there means covering not just science, but also the business of healthcare. The hospital there was the largest employer in the city, covering health policy, you know, just as it is now. Healthcare was really important in the state legislature, in the presidential primaries, which roll through New Hampshire from time to time. And it turned out that I actually was like probably more interested in the business and politics of healthcare than I was in the science of it. And so I've kind of stuck with that stuff.
How can people sort fact from fiction in the healthcare area? You know, I mean, we're certainly not short of information, overrun with information, more information than we could ever process. You know, some of it's legit. What you're writing is legit. A lot of it isn't. How can people tell the difference?
It's a really big problem. I mean, I think it's a problem in terms of like the kinds of things that I write about policy and business. But it's like I think it's actually a much bigger problem when it comes to sort of like science and treatment. And I don't have a really easy answer. I mean, I think if I were like giving advice to any of you about like how do you find the true information, I would say really look at what the source of that information is. And, you know, if the source of that information is the New York Times, then I think you can feel pretty good that the person who wrote that article spent a fair amount of time really examining the evidence, has probably developed some expertise in the area, and has like talked to lots of people and read lots of things before they wrote that article. If it is like some website in your Facebook feed that you have never heard of before, like it may be that the person who wrote that article knew a little bit less or had an agenda that they were trying to push. But I think it's really hard because I think, you know, I don't want to pretend like the New York Times is like the best or the only place to get information. I actually think there are quite a lot of really good smaller news organizations that may be less familiar to you that are like the best at certain kinds of news. But, you know, I think maybe you want to look at the source and try to figure out, do they have an agenda? Do they seem to have a track record of honesty? Do they have a good reputation? And if you're not sure, maybe you want to look at that piece of information and then also see what a place that you know to be reputable said about the same thing as maybe a way of kind of gut checking it.
Audience question for you, Margot. What has been your favorite topic to report on?
Oh, I don't know. I mean, I talked about Danish cement, right? I don't know what my favorite topic to report on has been. I think at the Times, covering the effort to repeal and replace the Affordable Care Act in 2017 was like a really exciting time for me because I felt like it was this moment in which lots of people were paying attention to health policy, and there were really great opportunities to explain stuff to them. So I feel like that was the time that I got to write that article about like, why does everyone have to pay for maternity benefits? You know, like what's the reason why they did that? And there were lots of other articles like that that were about these bills and about the politics around these bills, but were also about these really basic trade-offs and bits of knowledge in health policy and in health economics that suddenly I could get people interested in that, you know, might have been like a harder sell otherwise. But I don't know, I should have a better answer to that question. I had, when I was in New Hampshire, I covered a 7-month-long standoff between sort of right-wing extremists and the US Marshal Service. And like maybe that was like the most fun story I've ever covered.
What follow-up on what you were saying before, what websites, news organizations do you recommend other than the New York Times?
Oh, I think I'm just gonna skip that one. I feel like I don't feel like off the top of my head I'm gonna come up with a really good list. And I think it also depends a lot on what you're looking for news about.
Mm-hmm. Are there topics in health policy that you think aren't getting enough coverage or media attention, or perhaps topics that are getting way more than they deserve?
Well, I think that my list of my blend of topics is of course perfect and
You
includes
can't,
everything.
by the way, give too much coverage to the 60-year-old.
As someone who came up writing for a local newspaper and has really witnessed viscerally during the course of my career, the kind of hollowing out of local news, I think that the stories that are undercovered are stories that are happening at a more local level, or stories particularly about state policy, the kind of stuff that I used to do, going to the New Hampshire legislature, talking to lawmakers there and lobbyists, and understanding the influence of various entities at the local level. I think there are still really great reporters doing that around the country, and there are great stories of that sort, but I think there are fewer of them. And I'm sure you probably experienced this here in Minnesota, where there may be someone who's covering healthcare at their local paper, but instead of being like me and being a full-time healthcare reporter as I was, they might also have a bunch of other side gigs. And so I worry about that. I feel like I'm in this Washington bubble where we're covering kind of big national stuff, but I think a lot of what really matters to people in healthcare is happening at a much more local level, both in terms of policy and business practices. And I worry that there are fewer people really paying attention to what's happening there.
Audience question, studies show that a Medicare for All system would save $400 to $500 billion per year by eliminating our complex health insurance industry. Does this saving sound about right to you?
So I actually spent a lot of time looking at a wide array of estimates about the costs for Medicare for All, because I feel like it's a really important question, what's it going to cost? And I really came away feeling that anyone who is telling you an answer with a great deal of precision about the cost of Medicare for All is I would be somewhat suspicious of that person. So we don't really know. This would be a really huge change to the way that we do things, really huge. And there would be lots of small decisions about how it was structured and also how it was run that would have a big effect on the final price tag. And strangely, $500 billion is actually a pretty small number in the grand scheme of things. The U.S. is projected to spend somewhere in the neighborhood of $55 trillion on healthcare in the next decade, and so $500 billion here or there, that's a rounding error, right? What I think the consensus of all the estimates of Medicare for All shows is that if you take all that spending, all the spending that we spend on our healthcare system now, so that includes spending by the government, spending by states, spending by you guys when you pay your premiums or you pay co-payment at the pharmacy counter, payment by employers for premiums. If you kind of take the whole universe of stuff that people in the United States spend money on healthcare for in various ways, it looks like Medicare for All system is going to cost about the same amount. Some studies say a little less, some studies say more. But not dramatically less or dramatically more. I think I think it's reasonable to assume that it's going to be in the range of what we spend now. And then it's really just a question of changing around where that money is coming from. So under Medicare for All of those other categories that I just talked about basically go away, and we just have the federal government paying for everything. And that's a big change. That's going to lead, people talk about, taxes are going to have to go up so much. That's true. Taxes are going to have to go up on some people, on some businesses to raise that money. But of course, all these other ways that we're spending money on healthcare will disappear. So there'll be savings for people too. But it is such a large change in the way that our healthcare system works that I think it's just very difficult to estimate exactly what it is going to cost. If we have a president and a Congress that really wants to pass Medicare for All, we are of course going to have to get really deeply engaged in this question about $500 billion here or there, because the Congressional Budget Office, which is this nonpartisan scorekeeper that Congress pays a lot of attention to, they're going to have to come up with an estimate for what it costs. And their estimate is going to have probably a pretty big effect on the public discourse around the idea. And it may even have an effect on what Congress can do because of various budgetary rules. So there will be a estimate, but I just will point out that even though I really admire the Congressional Budget Office, and I think they are serious people working in good faith with no agenda, and I take their estimates seriously. They are often wrong because it's really hard to predict the future, and the bigger the change, I think the harder it is to predict what something is going to cost in the future.
Do we have any idea what would actually happen if private insurance went away? I mean, that's a key part of our current system. Medicare for all, they get rid of private insurance. Do we have any notion of what might actually happen if that were to occur?
I mean, we have some ideas. I mean, there's some like obvious kind of short-term stuff that would happen, which is like if you have a job working for an insurance company, like you would have to get a new job. If you get your insurance from, you know, a private insurance company, you would have to get new insurance. So those are like big changes. What the effects would be on the healthcare system, on delivery, and on patients in terms of what their ability to get care would be, I think are harder to know. I think the kind of most scaremongery versions of this that say that it would, you know, it would be way worse and no one would be able to get anything. I don't really see strong evidence for that. I mean, I think, you know, in Medicare, we have a Medicare system where most people over the age of 65 have a government health plan. There are some people who have a private alternative, but, you know, those people seem to be able to access doctors and hospitals and get pharmaceuticals for the most part pretty well. But, you know, it would be a big change. It would be some disruption. People would have to change the way that they get their insurance now, lots of them. The majority of Americans would have to get their insurance in a new way. And even the people who get Medicare now, it would be a slightly different program. So there would be changes, but it's hard to quantify them exactly.
Audience question, do you think healthcare providers and health insurance will be effective at improving social determinants and improving population health?
Maybe? I don't know. Like we're seeing, we're seeing some interesting stuff happening in this area now, at least theoretically. So the Trump administration is letting Medicare Advantage plans, so these are these private Medicare plans for people over 65, letting them pay for some stuff that's not medical care that used to not be allowed because it was seen as like not a good use of federal healthcare dollars to be buying people air conditioning or food or housing. We haven't really seen how that works out. Probably it's going to be relatively small bucks in the grand scheme of things. I think overall we have a system, and it's not unique to the United States, where the money is kind of siloed into these different categories. So the healthcare money pays for healthcare services, and the housing money pays for housing, and the food money pays for food. And I think it's really hard to come up with programs that mix them together. But I don't know. It seems totally possible that there will be some interesting innovation in this space. I know there are a couple of health insurers that are starting to pay for housing for chronically homeless people who have a lot of healthcare needs. There are some interesting pilots that are happening like that, but they're relatively small in just a couple of places. Seems possible that if those are successful, we could see that, for example, becoming a more widespread model.
Is there anything significant being done about the racial and ethnic disparities in healthcare? The fact that the quality of your care, accessibility of the care depends a whole lot on who you are.
I think that there is really clear evidence that these disparities exist and that they have been relatively persistent for a long time. I don't see at the federal level a lot of attention to this, to developing policies that counteract them. I think this is actually an area in which the states are doing a little bit more, and where, like, I wish there was more state reporting on this stuff so that I knew the answer to your question. I think it's, you know, it's an important issue that is looking for policy solutions, but I personally have not seen anything really exciting in this space in the federal conversation. But maybe one of you guys knows the answer to this question and will come up and tell us afterwards.
What about technology? I mean, we've seen huge technological advances over the years, and presumably there are a lot more on the horizon. What are you hearing in terms of potential breakthrough areas? Question number one. Question number two, how in the world can we afford those breakthroughs? If we're so concerned about cost today, I would assume if somebody came up with a way to deal with a cure for cancer, it would cost quite a bit of money.
So I feel like I have more to say about the second question than the first, except to say that, like, there are a lot of really exciting things coming out now. We're seeing, for example, like quite a few cures or close to cures for really rare diseases that, either led to early deaths or like really long-term disability for people. And so, there's like a cure for a certain kind of blindness that hit the market recently that seems, you give it to children and they don't develop blindness. It's like a huge thing. There's like new treatment that I think there's really good research on now that seems to really reverse almost all the symptoms of cystic fibrosis, which is like another example of an illness that can lead to a lot of long-term disability and early death for people. So there is a lot of really exciting science. It seems right now to be mostly focused in these kind of like narrow slices of disease. It seems like it has, it's like we're learning that diseases are like more and more specific. And so that means that more and more of our treatments are things that influence only a small slice of the population. I feel like the kind of holy grail of this sort is a really good treatment for Alzheimer's disease, which is like affects lots of people. It's like a really important public health burden, and the science has been somewhat disappointing on that so far. The whether we can afford it, I think, is really interesting and really fraught. And I think this is a question that also like gets to another one of these like big questions. So we always say the cost of healthcare in the United States is growing at a faster rate than our wages, growing at a faster rate than the overall growth in our economy. And like generally we say like that's bad, right? Like we don't want to be paying more and more of our GDP just to healthcare. There's lots of other stuff that we want to spend our money on besides being healthy. But like some things that we spend our healthcare dollars on are like really great because they make our lives way better. Like curing blindness seems like something that probably is worth a lot of money, and that is something that didn't exist before. And so it's kind of easy if you imagine healthcare as being like a fixed set of things over time to say like, let's try to squeeze down the price of that. Like we want to get the benefits from the stuff that we already have, but we want to get it cheaper. But healthcare is not really like that. There's like new technologies all the time. There's new treatments that are better. There's new drugs that are better. And trying to think about how much they're worth, how much more of our economy is it worth to get these improvements in health, is like a tricky question. I don't think that there's like an obvious answer to it. I think different people are gonna have different answers to it. And we're gonna, as these really expensive but really life-changing technologies continue to be developed, I think we're gonna keep having this conversation.
Prescription drug question from the audience. Why is the cost of prescription drugs so high in the United States? And what can we do about it?
So,
A yes or no answer.
I think we have a system that does not provide a lot of downward pressure on the prices that the makers of prescription drugs can ask for. And we also have a system that creates a lot of incentives for them to make as much money as they can on their inventions. And as I said before, that's like has good things and bad things. The fact that someone who invests in a pharmaceutical company or in pharmaceutical research could potentially like win the lottery if that drug is successful is a reason why we have investment in that sector. It's risky, most ideas for drugs are not successful. So most people, if for every dollar you invest in a thing, like you have a really good chance of getting $0 back. But if your dollar goes towards the cure for blindness, and the cure for blindness is super expensive, maybe you've got a winning lottery ticket. And so, like the higher the return when you hit it big, the more likely people are to risk losing their dollar on those investments. We have a for-profit system in that way where, most of the money is coming from private investment. Those people who are making those investments could take their dollars elsewhere. So, we have a system that is basically built to have really high drug prices. We have these profit-seeking companies that make the drugs, and we don't have a lot of downward pressure on the prices of drugs in the way that we purchase them. So I think there is like a lot of margin to lower the prices that we pay for drugs. There's lots of ideas about this. There's lots of ways to do it, but you could just like, most countries do is they just basically negotiate a set price and just say like, we, the country of England, are gonna pay, X dollars for this cure for blindness. And if the blindness cure manufacturer says, no, that's like way too low, then people in England don't get that drug. We don't really have this problem in the United States because we don't really walk away from the table very often. So we have the drug, it's just super expensive and some people can't afford it. But there's lots, and this is something we're gonna see in the presidential debate and also in a bipartisan debate in Congress. There's lots of ideas about what you could do to put more downward pressure on drugs. I think that could make drugs more affordable, but it could, again, influence the development of new drugs in the future if people who are investing there now think that it's not as good an investment as it was before.
What about the other countries, though? You know, you always hear, well, gee, just go up to Canada, you can get this stuff a lot cheaper or whatever. Are people in those other countries upset? Are they getting cut off? Do they have the same access to prescription drugs as we do? And they just get it cheaper? I mean, how does that work?
I think it depends on the country and it depends on the drug and the category of drugs. I would say, I don't know, someone who's more of an expert on this will know, but I think it's safe to say in general, people in other countries get most of the same drugs that we do for lower prices across the board. There are some drugs that they don't get that we get because we get them first, or they're so expensive that those other countries just won't pay. Usually they get them eventually, like the drug companies will kind of hold out for a couple of years and then say, fine, France, you can have this at this huge discount. But there is a trade-off. You know, drugs enter the market in the United States first. We have more drugs, but we pay a lot more for them. There's this idea, the Trump administration is letting some states experiment with buying drugs from Canada and bringing them to the United States so we can kind of get them at a lower price. I think that's like an interesting policy. It's very politically popular. It's been endorsed by both Democrats and Republicans over the years, but it's weird to me because like we're really just importing their price. Like it's the same drug you can buy here. So I feel like if you want the Canadian price, like maybe we should just pay the Canadian price. I don't know.
Mm-hmm. An audience member asks, I've heard the Medicaid and Medicare rates are low. What would Medicare for All do to the healthcare system if much of the country actually had Medicare? Better than ACA rates, worse, whatever?
So you've been talking to some hospitals, I can see. So in general, this is not true for every service, not true for every hospital, but basic model. Medicaid tends to pay hospitals like one price. Medicare tends to pay like just a little bit more. And then private insurance tends to pay like double what Medicare pays. So there is a lot of variation in that, but that's, I think, kind of like what the national picture looks like. And so you could imagine if you're a hospital and half of your customers are paying, let's call it one government rate, Medicare, and half of them are paying double that, and all of a sudden everyone is getting paid this rate, that's like, you know, it's a pretty big pay cut for you, the hospital, if you have to suddenly have all those patients that were paying double pay just the Medicare price. And so I think it is sort of indisputable that some hospitals and doctors are going to be worse off if they are all paid the amount that Medicare currently pays now, because they're used to having these higher paying customers. There are some savings too. So there's a lot of costs in hospitals that just go to like billing, dealing with insurance companies, like, you know, just dealing with the complexity of our system, that you have all these different payers that all have slightly different rules and systems. So there's a view that, you know, the hospital will have like fewer back office workers, and so they'll, even though the payment they get is less, they're going to have to, they can spend more of it on medical care and less of it on this other stuff, so they won't come out as poorly. And there are some hospitals now that actually make money on Medicare. They do just fine because they don't have a good negotiating position with private insurance companies, and they have just like found a way to exist and exist profitably, just being paid the Medicare price. Those hospitals would be fine, and maybe other hospitals could like learn to operate more like those hospitals. But I do think that there almost certainly will be some disruption, some conflict, some problems. There will be some hospitals that will probably close because they won't figure it out. There will be others that will have to really change the way that they do things because they're really expensive right now. They've gotten used to being paid at a certain price. There will have to be some kind of adjustment. I also think people talk about like Medicare prices, like that's like a fixed thing. Medicare is a system that every year reconsiders what it's going to pay for different things. There's like a whole bureaucracy that decides what does Medicare pay. And in some ways that's a policy question that's based on the costs of providing the services. In some ways that's a political question. Congress makes little tweaks and adjustments all the time. So if you had everyone in Medicare, it's also possible that then like what Medicare pays would be a little bit higher than it would be in our current environment, because those determinations about what it costs to provide care would change. So probably like a little bit of a haircut for doctors and hospitals, and probably some disruption, but maybe not as much as some of the most worried people say.
Advocates for Medicare for All say it's the only way to make sure that everybody in America actually has good health care coverage. I'm curious, why couldn't you, if you had the current system and added a public option, why couldn't everybody be part of that?
They could. I mean, if you look around the world, single payer is not the predominant model. Most other countries have some system where everyone is covered in some fashion, but they don't mostly have single payer systems. So this is an idea, I think, partially because we're right next to Canada that has a single payer system. So people here are really familiar with it, and the Canadian system works pretty well. It's really popular. I think also just because of Bernie Sanders being a very charismatic politician who has been advocating for this particular policy for a long time, and now is a presidential candidate with a lot of clout 2 races in a row, like this seems to be the model that people are talking about. But you know, there are a lot of countries that cover everyone with what are called multi-payer models, where you have both government and non-government sources of insurance. And it's possible that a public option kind of plan could be something more like that. I mean, the Affordable Care Act obviously was designed to kind of take the existing system that we had and like try to plug some holes. I sort of think about it as like, you know, kind of like a weird old house, like got a lot of wings that don't really match each other, and like the roof was leaking, and so like, you know, the construction crew came in, they put another wing on, they fixed the roof, they put like nicer, more energy efficient windows in. That's how I think about the Affordable Care Act. You still have a weird house with wings that don't really match each other. So I think a public option is like more like putting another new wing on that house. Maybe it's a little bigger, maybe it's a little bit fancier, maybe some of the really weird decrepit wings, like people will leave them and go into the new wing, and so it will be a little bit better, but it's still kind of a weird system. I think the aesthetic appeal of single payer is you just like tear it down and build your dream house, right? Like all the weirdness is gone, you can like build something from scratch that's like really wonderful and that aligns with all of your values. But that does involve like tearing down the house, and so that's a political challenge.
Audience member asks, Margot, what are you most excited about regarding the future of U.S. healthcare?
I don't know. I think part of what is fun about my job is like I don't control the future, but I just like get to learn about it and write about it as it happens. And so I'm just like, I think it's an exciting moment because we're having an election in which healthcare figures so prominently, and so that means that we're really, I think, serious people are thinking and engaging with these ideas in a way that they don't in every year. And so I think we're going to have a debate about like, what do we think about single payer? Or what do we think about the weird stuff about our healthcare system? What are the best ways to fix it? We don't have that every year. Like healthcare is not always a front burner issue. So I'm excited about that, but I'm also, I don't know, I'm just like excited about what I'm going to learn tomorrow that I don't already know about how the world works, about how the healthcare system works.
What's it like covering a subject matter that is so politicized, so polarized, frankly, at a time when there's such distrust of the news media? I mean, do you get a lot of static?
I personally don't get as much as some of my colleagues that cover more explicitly political stories do. So I feel grateful for that. I think it's hard, you know, I mean, I just, for the most part, like, what I try to do is like put my blinders on to all of the like yelling and just try to focus on like, what's the truth? And, you know, how can we help people understand the world better? And like, you know, I think there is value in that. And I think that probably that is the best value that I can provide in this environment, is just to like keep explaining things clearly and keep doing my job fairly. But yeah, I don't know. It's definitely like noisy and contentious. It's a little less noisy and contentious around healthcare at this moment, but I think once we get into a general election, I think it will probably be a little bit hotter in that way.
What do you think the focus of that hotness will be, the focus of that debate as we get closer to the election?
I mean, I think a lot of this debate, particularly, I mean, it really depends, I think, on who the Democratic nominee will be. I think if we're having a debate about Medicare for all, about a single payer system, you know, a lot of the debate is really going to be sort of about values, right? Like, you know, the ideas behind Medicare for all have to do with like, do we think that like everyone should have the same thing? You know, that's a values question. And I think that's part of why it will be so hot, you know? What do we think is the proper role of government? Should government have so much control over this really important aspect of our lives, over this really important part of our economy? I think, you know, people really disagree about that. So, you know, you can already see the president sort of gearing up. He talks a lot about how, you know, he's going to fight against socialism. He doesn't want the government controlling this huge part of the economy. And you hear politicians, you know, particularly like Bernie Sanders, really talk about like, this is about fairness and equity and making sure that everyone is taken care of. You know, I think these are emotional issues, and that's part of why you see such sharp disagreement.
Do you get the sense that there is a broad area of common ground with Republicans, Democrats, or is every virtually every aspect of this debate contentious.
So I recently was part of a polling project that with the Harvard School of Public Health and the Commonwealth Fund, which is a sort of healthcare philanthropy and research group. And we basically we put people in like 3 categories. We asked them like, here are 3 possible ways that the health insurance system could work. Which one do you like the best? One of them was sort of like a Republican block grant, state block grant kind of plan. One of them was a little bit like a Affordable Care Act with some enhancements. One of them was a single payer. And we said, like, you have to pick one of these 3, not just like, do you like any of them, but which one do you like the best? And then we asked them a bunch of other questions about, you know, what do you think about some of these values questions? And one thing that stuck out to me is there are quite a few things that no matter what your policy preference is, no matter what your politics or age or basically any of these other crosstabs, there are some things that people agree on. And one thing that people seem to really agree on now, which is not true in the past, is that people with pre-existing health conditions should be able to obtain health insurance and get the same access to healthcare as other people. So I think that is like, I didn't talk about this as like the legacy of the Affordable Care Act, but that's like a huge thing that the Affordable Care Act did, is I think it changed people's sense of like what is normal and expected around that. There also seems to be some differences between the groups, but there seems to be some agreement that everyone should have a right to have access to healthcare, regardless of how much money you have. And so I think, those are the kinds of things that, as we see more and more voters of different political persuasions agreeing on, that probably we're going to have policy that reflects those values.
Is it even feasible, Margot, for everyone at some point under some system or other, that everybody would have access to world-class, Mayo-style healthcare in America? Or is that always going to be restricted to people who, for whatever reason, have access the other people don't? They don't have the money, whatever.
I mean, you could imagine in a single payer kind of system where everyone has access to all the same stuff, then, everyone would theoretically have access to Mayo-style coverage. I think the challenge of that is, like, the Mayo Clinic would be different in that environment. I was talking about the hospitals that get a lot of the double the price stuff. Like Mayo, I think, is a good example of an institution that, sort of rich people with good insurance from all around the country come there and pay them for services. And so that is part of what enables them to do the world-class stuff that they do. They just get more money than other hospitals. Mm-hmm. I think people are also always, even if everyone has the same health insurance, I think people are still going to have other kinds of disparities based on their income and education. And I think one obvious one is just their ability to travel. So people come from all over the world to go to the Mayo if they're rich enough. It's not just because they have insurance. It's also because they have the ability to take a week off from work. They have the ability to buy a plane ticket and come here, get a hotel room, those kinds of things. I think those differences are not necessarily going to go away if everyone has access to the same institutions on paper. Mm-hmm.
Lots of students here. What's the best way for those students to prepare themselves for a career in health policy?
I assume that you guys are doing it right. You're studying it at a great place. I have no official training in health policy, and so I feel like the training is something that I leave to the professionals. But I think if you're excited about this stuff and you're engaged in it and you have smart questions, I feel like that's the right way to do it. I sort of think of people who study health policy in a academic professional setting as being sort of my people, because I think a lot of what makes their work good when it's good, and a lot of what makes my work good when it's good, is just asking smart questions and then finding out what the answer is. So I don't know, I guess my advice would be to just, keep working on really smart questions. I think that's true for policymakers too. You got to ask the right question in order to get to the right answer.
For budding journalists, is this a good area for them to think about, hey, I want to be the next Margot?
I think it's a great area because it's all in there. I think healthcare is everything, right? It's super emotional, it's super personal. Everyone goes through it, right? Everyone interacts with the healthcare system. It's not some niche thing over to the side. It's a huge part of our economy. It's a huge part of our politics. The stakes are really high. And I think no one has an easy answer. I think it's just legitimately hard. Trying to figure out how we're going to make everyone healthy is really hard. And I think that makes it really interesting and ripe for journalism, because there's just lots of conflict, there's really high stakes, there's personal stories, there's emotion, there's dollars, there's politics. journalism is a really tough business. It's like I'm so every day, like wake up feeling so fortunate that I get to do it and that I get to do it at a place as good as the New York Times. And I don't think that that is like entirely a reflection on me or my skills. I think it's like, oh, there's a lot of luck involved in my ability to have gotten to this place in this part of my career. So I would say, like, if you want to be a journalist and you have the ability to be a healthcare journalist, I think it's enormously, enormously rewarding. But I also think if you want to be a journalist and like the opportunity lies in some other area, like do the journalism that you can do, because I think journalism is great work, and you know, the jobs aren't always exactly where you want them to be.
Sounds like you are having fun, though.
Yeah, yeah.
Well, Margot, we're out of time, but I want to thank you for joining us today.
Thank you so much for such good questions.
Margot Sanger-Katz, thank you for joining us. Thank all of you for being with us. And Gary Eichten here.